Good afternoon, everyone. Thank you so much, Leigh Day, for having me, and thank you all for being here. And also thank you to all the incredibly powerful and inspiring words we have heard from our speakers thus far. So my name is Elinor Cleghorn, and I am the author of Unwell Women. Unwell Women traces the historical roots of gender bias in medical thought and practice. We know that for far too long, women have been impacted by social, cultural, and racial biases that have culminated in what we now refer to as the gender health gap and the gender pain gap. So this afternoon, I want to talk about how those gaps were forged over more than 2,000 years of medical history. And I'm going to try and race through and explain why these histories of neglect and mistreatment continue to impact women's healthcare and women's treatment within the medical system to this day. So my book, in many ways, is a call to arms for more compassionate, informed, and effective health and medical care for all women. Today, as we imagine and work towards an equitable future for women's healthcare, I think it's more vital than ever that we face up to medicine's historic complicity in creating and endorsing myths, misbeliefs, and misunderstandings medicine's historic complicity in creating and endorsing myths, misbeliefs, and misunderstandings about women's bodies, minds, and health conditions. And these myths and misbeliefs are deeply ingrained into medical knowledge, and they are the roots of the gender biases and health disparities that we're striving to overcome. But before I dive into this fascinating and frankly infuriating history, I want to talk about how I came to write Unwell Women. I wrote this book in late 2019 and through 2020, mostly during pandemic lockdowns. But the thinking that germinated Unwell Women really began in 2010, in the months after I was diagnosed with an autoimmune disease called systemic lupus erythematosus. I'd just been through a complicated and quite traumatic pregnancy. During a routine ultrasound when I was about 30 weeks pregnant, my unborn son's heart was found to be beating far too slowly. After I was referred to fetal cardiologists at the brilliant Elinor Children's Hospital here in London, it was revealed that my unborn son had a condition called congenital heart block. This condition is very rare, but it's closely associated with mothers who carry autoantibodies that cross the placental barrier and attack the fetal heart. And these autoantibodies are strongly associated with lupus. So I had a blood test and it turned out I did carry them. My doctors and consultants were completely focused on saving my baby's heart, and thank goodness they did, because he was born healthy and well. But nobody ever explained the implications for my health. When my son was 9 weeks old, I was rushed to hospital with a resting heart rate of about 190 beats per minute, and I was scarcely able to breathe or walk. My heart was failing. An ultrasound showed that I had extensive inflammation in my pericardium. But none of my doctors could figure out the cause. No one connected the dots between what was happening to me and what had happened to my baby, even though my pregnancy history was all over my notes. So after about 10 days on the cardiac ward, a visiting rheumatologist came to see me. He spoke to me, he ordered an immune assay, he studied my notes really thoroughly, and he gave me a more or less conclusive diagnosis of lupus. He explained how the same disease mechanism that had attacked my baby's heart was now attacking my own. I was referred to a brilliant NHS clinic at St Thomas's for lupus and the allied diseases, and finally given the correct medication. And slowly, I embarked on the road to some sort of recovery. My consultants explained that I probably developed lupus in my late teens or early 20s. They told me the flare I had just experienced might have been triggered by the estrogen changes in my body after I'd given birth. They also told me I was more predisposed to lupus because I was female, although they weren't exactly clear on the reasons why. My diagnosis was frightening and confusing, but it was also a relief and a vindication. Throughout my 20s, I'd suffered debilitating pains in my joints, along with migraines, photosensitivity, digestive issues, cognitive and mental health symptoms. And every time I went to the doctor to find some answers, I was dismissed, undermined, or patronized. I was told that my pain was nothing serious. I was told it was probably just my hormones. I was told it was growing pains at the age of 23. Some doctors assumed I must be leading a very unhealthy lifestyle, or that I was overweight, or that I was work stressed. One asked if it was possible that I was pregnant and didn't know it. Others just accused me of being anxious, overly sensitive. One said I was paying too much attention to my body. I was never referred for any diagnostic tests or complex blood work. I was never prescribed any medications or therapies to help me manage my symptoms. So over the years, I just internalized what my doctors were telling me and convinced myself that my pain was all in my mind and that I was anxious or a hypochondriac or even a hysteric. So my diagnosis gave me the chance to rewrite my history. It also prompted me to start mining medicine's history for answers that my consultants couldn't give me. Why was lupus so hard to diagnose? It takes between 4 and 6 years on average from the time a patient first reports their symptoms for them to receive a conclusive diagnosis. Why were there no solid explanations about what causes the disease? Why was it so unpredictable and the range of its symptoms still so poorly understood? I had the hunch that it might have something to do with the fact that around 90% of sufferers are women. I was an art historian working on my PhD at the time of my diagnosis, so it was already my impulse to look to the past in order to understand where we are in the present. I started mining medicine's history literally by Googling lupus 19th century, and I came across many case studies and reports and stories of women in history whose experiences felt achingly similar to my own. One of the first unwell women I encountered in the archives was named Grace. In 1902, at the age of just 18, Grace was admitted to the London hospital with pain in her joints and her chest. For years, she'd suffered intermittent rheumatic pain, so-called emotional symptoms, rashes all over her body and troubles with her heart, all of which had gone undiagnosed. She became very ill in hospital and tragically died after pain gripped her heart and robbed her breath. Her post-mortem revealed that she had inflammation around her heart, which was exactly the same symptom I was hospitalized with and which precipitated my own diagnosis. Grace's doctors at the London posthumously diagnosed her with lupus. In their report, they stated that lupus predominantly affects young women. They explained that the disease was exceptionally difficult to diagnose, and they said that it caused diffuse and unpredictable organ damage. Yet I thought while reading this about all those years that Grace's pain, like my own, had been ignored and dismissed. And it struck me that whilst biomedical knowledge might have progressed exponentially over more than a century since Grace's death, the kinds of attitudes towards female pain that contributed to her disease being overlooked and diagnosed woefully too late, very much in play in the 21st century. I felt a real sense of kinship with the unwell women like Grace, whose stories I was uncovering in the annals of medicine. As I came to terms with my own diagnosis, I noticed how issues of medical gender bias, especially around chronic conditions that predominantly affect women, were gaining traction in the press, especially online. I began to understand that stereotypical assumptions about women's pain and their relationship to being unwell were impacting their diagnoses. My eyes were opened by the pioneering 2001 study, The Girl Who Cried Pain, by American lawyers and legal scholars Diane E. Hoffman and Anita J. Tarzian, which revealed that women were statistically more likely to be offered antidepressants or sedatives after reporting chronic pain to a healthcare professional. I learned about how other diseases that affect women, including endometriosis, uterine fibroids, polycystic ovarian syndrome, and many of the autoimmune diseases, were mired by years-long diagnostic delays and misdiagnoses. And all too often, this was because women's verbal accounts of their own symptoms were not being taken seriously as indications of underlying diseases. Women's pain was too often being dismissed and written off as anxiety or emotions, or it was minimized and normalized as the expected consequences of simply living in a female body. So over the decade or so after my diagnosis, these issues were steadily gaining more mainstream media attention. And when I started writing the proposal for Unwell Women, it felt really important to not only explain what was happening, how women were falling into these health and pain gaps, but also why and how it all began. So Unwell Women was born of my immense gratitude to women like Grace, whose suffering contributed to the medical knowledge that saved my life. But it was also born out of my frustration and anger that women's suffering had been magnified across history because of ingrained mythologies about women's bodies, minds, and especially the causes of our diseases and health conditions. So how exactly did we get here? And why do these antiquated gendered misbeliefs still haunt and obscure medical care to this day? So the problem begins right at the very beginnings of modern medicine in ancient Greece, with the foundational treatises on human illness and healing authored by physicians associated with Hippocrates. The Hippocratic Oath to first do no harm became the cornerstone statement of medical ethics. And the Hippocratic physicians, writing during the late 5th and throughout the 4th centuries BCE, originated our empirical evidence-based approach to medicine. They untethered disease from the realm of the supernatural and debunked the ancient idea that ill health was punishment doled out by vengeful gods. So far, so good. But they also held very particular ideas about how male and female bodies worked and how and why their illnesses manifested. Ancient Greece was, of course, a deeply patriarchal society. Women were primarily vessels for reproduction, so medical understanding of the female body centered around the uterus or womb. I'm sure some of you might be familiar with the fantasy of the wandering womb. Well, the Hippocratic physicians believed that since childbearing was the point of women's existence, that the uterus literally hungered for marital sex and procreation. And they believed that if the womb was not moistened by, and I'm sorry for this phrase, male seed, or weighed down by a growing fetus, that it could actually start creeping around a woman's body in search of moisture, impacting the liver, the heart, the lungs, or maybe even the mind in its wake. So the medical theory of the wandering womb set a precedent, believe it or not, for the myth that women were not in control of their own bodies, that their bodies were out of control, and that their bodies needed the social cure, the misogynistic social cure of marital sex and pregnancy to attain anything like the equilibrium of health that could be enjoyed by a male body. Coupled with the idea that the female body was an inferior, mutilated version of the superior man, this created potent conditions for the denigration of women's bodies that dominated medical thinking into the Middle Ages. After the 4th century CE, Christianity was the dominant religion across most of Europe, and medical knowledge consisted largely of translations of these foundational Greek and Roman texts, like the Hippocratic corpus, and most of this knowledge was owned and controlled by men of the church. So Hippocratic medicine, with its wandering wombs, was now being reinterpreted in light of new reigning beliefs informed by Christian theology. The myth of Eve meant that women were perceived as being responsible for unleashing all the sin in the world. And so medical law about female biological inferiority and women's unruly wombs was now being respun as something of a moral issue. Because women were so closely associated with the irrational, messy realm of the body, they were not thought to have any rational control over what their bodies were doing. Pseudo-medical religious texts prevailed throughout the Middle Ages. And in the 13th century, a book called Secrets of Women, written by an anonymous follower of St. Albert the Great, became wildly popular. It purported to be a guide for celibate priests and churchmen about human reproduction, a sort of textbook about the mysterious inner workings of women's bodies, which of course these men swore to never have any contact with. But this book, in fact, was just a bunch of vicious lies about the monstrous nature of the female body and its biology, especially menstruation. Its author claimed that women were so compelled to procreate that their bodies forced them to perform violent and dangerous injuries against men, including luring them into sex only so they could transmit injuries and illnesses to the penises. This was a very popular book. Just to let you know, it went viral. The fundamental message of this kind of religious propaganda was that women's bodies and minds were not to be trusted. These punitive, pernicious medical beliefs informed the intense culture of suspicion that was blooming around women's bodies. The notion that what lay beneath a woman's skin was untamable and dangerous inflamed the justification for accusing, trying, and executing women for supposed acts of witchcraft in Europe between the 15th and 17th centuries. Women were thought to lack rational control over their bodies, so it was easy to explain away their tendency to consort with the devil. Although medical knowledge was not wholly responsible for the horrifying persecution of about 45,000 women across Europe during this time, it certainly contributed to the misogynistic attitudes that were part of this thinking. So by the early 17th century, some medical men were at least trying to offer a more humane understanding of how women's bodies worked and what might be causing their illnesses. The notorious diagnosis hysteria first emerged into medicine in 1603 when an English chemist named Edward Jordan proposed that it might be a slightly more plausible explanation for the physical and mental symptoms of witchcraft than having sex with the devil. Jordan proposed that women's uteruses had such a profound influence on their health that afflictions of the womb could make a woman appear to be under the dominion of spells. Hysteria as a blanket diagnosis for women's illnesses gained credence throughout the 17th century thanks to influential physicians like Thomas Willis and Thomas Sydenham. Both these physicians really pushed the message that hysteric symptoms, which soon included almost any conceivable physical or mental symptom, were caused by women's weaker and more delicate nervous systems. Physicians like Willis and Sydenham set in motion a truly worrying trend for labeling all of women's illnesses as hysteric and explaining most symptoms away as some kind of consequence of women's nervous weakness. By the beginning of the 19th century, hysteria and female nervousness were fast becoming the most popular diagnoses for women's illnesses, especially for gynecological conditions. The idea that women's pain was always exacerbated by some combination of her unruly womb, delicate nerves, and impressionable mind meant that many serious diseases were being swept under the hysteric rug. One woman whose story always haunts me died in 1807 after suffering pain in her uterus for 25 years. She was referred to in her case studies only by her initials, JS. JS's autopsy revealed that she actually had extensive damage in her pelvic organs and colon, but the doctor studying her case wasn't convinced that this could have caused the pain that she was complaining of for 25 years. Besides, when women spoke up about their pain in the 19th century, it was often interpreted to mean their pain wasn't real. Voicing one's pain was one of the symptoms of hysteria. JS's doctor combed through her notes and fixated on comments that doctors had made throughout her life about her emotional ability. He eventually gave her a posthumous diagnosis of hysteralgia, which simply means uterine pain, but was chosen very specifically for his hysterical connotations. So theories about women's pain, about how serious it is, whether it is real or imaginary, its origins and causes, and what kind of women feel it, gained prominence in the 19th century. Some physicians believed the influence of women's minds on their physical states was so strong that they were even capable of inducing breast cancer with their sentimental feelings. Others believed that women who were leisurely, higher class, and enjoyed the spoils of colonial wealth were far more sensitive to pain than working class women and women of colour. This pain scale linked the capacity to feel pain to a woman's apparent civility. And this was, of course, informed by racist and classist misbeliefs. Racist anthropologists in the early 19th century often claimed that women in the colonized nations bore pain easily. And this idea was embedded into medical thinking around how Black, Indigenous, Asian, and ethnically diverse women feel and tolerate pain. The horrific falsehood that Black women feel less pain than white women, which is a bias that very much persists today, originated, of course, as a justification for the horrors of chattel slavery. And in the 19th century, as gynecology was becoming professionalized by male physicians in the UK and the US, this misbelief had truly harrowing implications. James Marion Sims, an American gynecologist working in the town of Montgomery in Alabama in the early mid-19th century, was once lionized as the father of American gynecology. But he achieved prominence by performing experimental surgeries on enslaved women whom he had purchased in his backyard hospital. Sims' autobiography, where he describes perfecting the procedure for repairing injuries, including vesicovaginal fistula, make for extremely difficult reading. But I think it's imperative that we face up to the realities of these episodes in gynecological medicine's foundations and afford Sims victims the dignity, respect, and humanity they deserve by honoring their role in medicine's history. So the 19th century saw many physicians attempt to forge their reputations and line their pockets by insisting on the necessity of surgical solutions for female problems. The notion that women's minds and reproductive organs were indelibly linked made it easy for certain surgeons to prescribe interventions including ovariotomy, myomectomy, clitoridectomy, and hysterectomy, not only for physical disease, but also for behavioral issues, including nervous instability. Towards the end of the 19th century, many physicians of women's diseases in the UK were pathologizing women's menstrual disorders, not only as reasons to perform completely unnecessary surgeries on them, but to recommend that they were barred from pursuing any kind of life other than marriage, motherhood, and homemaking. So as women's cause for the expansions of their rights began in earnest in the 1890s, sexist physicians really doubled down on their insistence that young women were completely unsuited to schooling, college, or the workforce because they bleed. Doctors like the notorious Edmund Hammond Clark wrote a whole pamphlet explaining that young women needed to rest during their periods because menstruation depleted all their energy. If young women used up their limited energy reserves by thinking and studying, their menstruation would become disordered, their reproductive organs would fail, and they would leave school or college unmarriageable and infertile. If women were permitted to be educated to the same level as men, then according to Dr. Clark, the UK was going to be overrun with armies of wasted spinsters. Thankfully, the end of the 1800s saw women in the UK and the US finally granted the right to practice medicine with a license. And for many of these female physicians, denouncing medical misogyny was quite high on the agenda. Mary Putnam Jacobi, a hero of mine, decided to conduct research into women's lived experiences of menstruation so she could see for herself whether having your period had any discernible effect at all on your mental state. She surveyed and examined nearly 300 college-aged women in the US where she worked and concluded that periods happen to the body, not the mind. A groundbreaking discovery for the time. She showed that menstruation was only debilitating to those with underlying diseases and that enforced rest was by no means necessary nor desirable. So thanks to figures like Putnam Jacobi, medical misogyny and some of the old myths and fallacies that were knitted into it were beginning to lose their power. Into the 20th century, as more chronic diseases were being identified and named, hysteria was also losing its power as a medical diagnosis for all of women's ills. But despite the extraordinary progression of medical knowledge throughout that century, the ingrained myths about women and illness were still being threaded into new, more scientific understandings of disease. When endometriosis was named and studied between the 1920s and the 1940s, physicians assumed it was caused by women choosing to put off childbearing. The theory that uninterrupted menstruation caused endometriosis persist today when women are wrongly advised that becoming pregnant might cure the disease. These physicians were also certain that endometriosis only affected white, well-off young women. This misbelief meant the disease was not recognized as affecting Black and ethnically diverse women until as late as the 1970s. Multiple sclerosis, which affects few more women than men, was wrongfully diagnosed as a hysteric illness in many women sufferers in the 50s. And assumptions that women's emotions directly impacted their digestive health led to prefrontal lobotomy being performed as a cure for ulcerative colitis in the 50s. Also in the 50s, the certainty that women's mental health was to blame for their chronic pain meant that many undiagnosed sufferers of lupus had endured years of unnecessary psychiatric treatment, including electroshock and insulin coma interventions, before they were properly cared for. In the 1970s, when feminism began to inform women's health activism in UK, Europe, and the US, women were beginning to rise up to demand that their health needs were disentangled from these damaging beliefs and antiquated stereotypes about what their bodies were for and how they should live their lives. For too long, women had been denied autonomy over their own bodies. Centuries of ingrained shame about what it meant to exist in a woman's body had forced women into silence. But now grassroots groups of health feminists were uniting to speak up and out. They began to create their own forms of knowledge and care because they sought to reclaim the understanding of their bodies on their own terms and not have that knowledge simply be the province of white-coated expertise. Today, thankfully, we hope that women who are navigating their health needs are not being diagnosed with hysteria or with the wandering womb. Yet, as we all well know, these old stories cast long shadows. The call of women health activists and campaigners from the 70s onwards for collaborative, compassionate, accessible medical care, and for women to be listened to and believed as the best narrators of our own bodies is as urgent today as it was 50 years ago. For so much of medicine's history, women's bodies and minds have been shrouded in sexist myths and patriarchal misbeliefs, while objective knowledge about our health conditions and diseases has been devalued, deprioritized, and neglected. We urgently need to disentangle and uproot these antiquated prejudices about how women experience and express pain. These prejudices which have been baked into medicine as gender biases. And it is high time that women's intimate knowledge of their own bodies and pain is trusted, respected, and taken seriously. Facing up to the ways that gender biases have been entrenched over medicine's history is one step in the fight to expose and eradicate these biases. By understanding how profoundly the neglect and pathologizing of women's bodies and minds has impacted medical knowledge and practice in the past, I think we can begin to move together towards the equitable medical future that we all deserve. Thank you.